Welcome to the Behavioral Health Matters podcast, brought to you by Magellan Behavioral Health of Pennsylvania. Our podcast mission is simple. We are dedicated to having conversations focused on positive mental health, increasing understanding of behavioral health services, and most importantly, reducing stigma in our communities. I'm John Lees, your host and member and family advocate at Magellan of Pennsylvania in the Lehigh Valley. On this episode, we are tackling a major priority in healthcare, children's behavioral health, and we have the perfect guest to help guide the conversation. Dr. Jamie Hanna, National Medical Director of Children's Behavioral Health at Magellan Healthcare. And a quick reminder, remember to hang out with us until the end of the show to find out how you can share your feedback and help shape future episodes with your suggestions. This podcast is for informational purposes only and does not constitute medical or clinical advice. Individuals should consult their provider for care decisions. And now here's my conversation with Dr. Jamie Hanna. Hello there, Dr. Hanna. Welcome, and thank you so much for joining us for this episode of the Behavioral Health Matters podcast.
Thanks for having me.
It's great to have you. So if you would, could you tell our audience a little bit about yourself, including your current role at Magellan Healthcare?
So I currently serve as the National Medical Director for Children's Behavioral Health at Magellan. I am a child and adolescent psychiatrist and also infant trained in psychiatry as well. So I took a little bit of an interesting course to psychiatry. In my undergraduate training, it was in child development. So I was working with children, working with younger kids, and I actually qualifies me to certify a preschool. So I kind of went into medical school knowing that I wanted to work with kids and families, and decided to start in pediatrics when I finished medical school. So I started my pediatrics internship in New Orleans in 2005, which is the year Hurricane Katrina hit New Orleans. And so I had just started my residency, and there were some significant changes to the medical resources in the city. And there was a huge need for behavioral health, particularly for kids, that just wasn't available. A lot of physicians and other providers had left the city, and it had never been an emphasis of some of our bigger hospital systems in the city. And so once we were reestablished as a pediatric residency, after Katrina, a few months after Katrina, I started to look to shift and transition to both my general psychiatry and child and adolescent psychiatry fellowship residency, which I completed in post-Katrina New Orleans. So it was a really unique experience. One of the things that I think was really different is that I expected a very academic experience in medical school, and it wasn't that time in New Orleans. It was about building systems. It was about finding resources, creating resources, and utilizing resources in novel ways. And so I had lots of opportunity to train. I opened a lot of hospitals. I closed a lot of hospitals, but worked on building resources and trying to help, both adults in my general psychiatry and children in my fellowship access resources. And so after my residency, I became faculty at LSU where I trained, and was director of one of the inpatient units at Children's Hospital for Behavioral Health, and then also director of consult liaison and emergency services at the hospital. And I think I had a unique opportunity there because I think psychiatrists sometimes are seen in a different way by other medical professionals. But because I had done my pediatrics training there and had worked with all of the doctors and nursing staff and all of the other, kind of key players as a pediatrician for a long time, I think I had a little bit of a different experience and a really integrated kind of opportunity to engage with everyone there. And so I was there for about 10 years, running those services and then also training residents, fellows, and medical students across pediatrics, general psychiatry, child psychiatry. And then I had a little bit of a brief stay with the freestanding facility outside of that academic environment, and then came to Magellan as the medical director in Louisiana for their high fidelity wraparound program, the coordinated system of care. And from that time, I've kind of moved into my current position where I get to work across more of our programs.
Wow. So what a neat path to where you are now. A pretty intense one, I would say, in a lot of ways, it sounds like, in terms of what was happening in the environment. And I'm interested to know, how do you reflect on that in terms of how it impacted the direction and the decisions you made about, what you wanted to do?
Yeah, I think if Hurricane Katrina hadn't come, I think I would be a pediatrician. I was thinking about how I would specialize, and looking at opportunities. But I think, a lot of the youth that I worked with, who I really had incredible engagements with, had experiences that, interface with behavioral health and that needed behavioral health support. And so I think it was an interesting transition. I think the biggest transition was going from being the pediatrician who was really comfortable with working with those types of topics to being the person in the room who had the expertise to work with those topics. And so that was a big shift. Post-Katrina New Orleans is hard to describe. And so it in itself was a unique experience, and I think definitely shaped the kind of provider that I am. I think it's different to have been trained as a pediatrician, because I think the medical model is different than the approach. One of the things that, I work very hard to remind people, hey, I'm a psychiatrist, but I'm also a medical doctor, which I never had to do when I was a pediatrician. But also in the background of that, remembering that child psychiatry actually didn't come and develop as part of the medical model development. It came through social work and the other child-serving services. As we moved out of Katrina, we were seeing an increasing presentation for behavioral health symptoms, right? And so it was a significant shift from prior. And as people started returning to the city, and the experiences that people had, which were significant, there was clearly a need, and a lot of providers were established in other places. And so it was a unique experience. At one point, all of our mental health clinics for the city were in one building. And you would go down, depending on what area of the city you were from, you would go to that clinic that was down the hall, because that was a building that was stable and available and a area that hadn't flooded. And so it was a unique experience. It was a wonderful experience to be here and be a part of the community. New Orleans is a really strong community, but it definitely shaped my training, and I think kind of the physician that I became.
And now, a brief word from Magellan. When you're caring for a child with autism, it can feel overwhelming trying to sort through all the different interventions, tools, and strategies out there. Magellan Healthcare's autism experts help make the process easier. They review and curate evidence-based resources designed to support everyday life and empower parents, families, and caregivers along the way. Through the Autism Marketplace, you can explore online and tech-enabled tools that support real-world challenges, like GPS safety solutions for children with special needs, mobile training that helps reduce challenging behaviors, and practical screeners and guides for developmental differences. To learn more, visit magellanhealthcare.com/autism-marketplace. That's magellanhealthcare.com/autism-marketplace. And now, back to the show. Just kind of shifting a little bit into talking about the structure and the organization here at Magellan and your role within that context. So for your national medical director responsibilities, I'd like to learn how your team is aligned across the country, and more specifically, how you coordinate efforts in collaboration with Magellan's other state medical directors. And if you could let us know and talk to the audience a little bit about the different states where you have oversight responsibilities in children's behavioral health. And if you can, provide maybe an example or two of the respective areas of focus.
One of the most important parts of my position is to create alignment across the team's markets and lines of business. And so we work with children in almost all of the markets where we work. And children's behavioral health is complex, right? We're not just talking about a single person. We're talking about the youth in the context of their families, and often multiple systems that they're interfacing with. It may be behavioral health, physical health, school, child welfare, juvenile justice, developmental disability services, and other community providers. So because of that, there has to be kind of strong clinical leadership and program oversight specifically around those children's services. So that's a big piece of my job, is to ensure that we're aligned across the different markets. Another big part of my job is to make sure we're not working in silos. So within the organization, bringing together and working closely with the clinical team, the operational team, network, quality, product, business development teams, ensuring that our strategy and our approach is aligned, that it's evidence-based, that it's, strategically moving forward and using the best, interventions that we have to be successful for kids and families. And because I have line of sight across all of our markets and all of our children's programs, I think I have like a unique opportunity to bring the things that we learn in an individual market forward to make sure that we're improving kind of across the board, and always looking to make sure that we're doing the things that improve access, that address barriers for families, gaps in services, opportunities to engage providers in more meaningful ways, and make sure that we're tracking the kind of outcomes that tell us how we're doing, and doing that in a standardized way across all of our children's programs. At Magellan, we have a number of programs and markets that we're really proud of the work that we do, where we work across the age population, right? So that in Idaho and Pennsylvania, in New Mexico, we work with members of all ages. Where I spend a lot of my time is in our programs that are really devoted specifically to kids. And so I mentioned that I started in Louisiana. The Louisiana Coordinated System of Care is our initial program in Louisiana, and it's a high-fidelity wraparound program. And that's similar to a number of our other programs that we work in across the states. So the other places that you'll see us, Louisiana, Nevada, Wyoming, Florida. In each of those spaces, we're working specifically with children's programs, and kind of working to keep some of the most complex youth, keeping them home and in the community to receive services.
So it sounds like, sounds like it's very helpful is you have this line of sight. Like you said, the scope is big, so you can see all of the different sites and what's happening, and then leverage some of those strengths and best practices and things that are working well to maybe implement in another place geographically. So that sounds like a real strength in terms of the capabilities of the organization and how they've set things up. So there's probably common programming and needs, I assume, across all offices. But are there some specific maybe needs or nuances as well? And if so, how do you guys as a team tackle those?
So I think each of the states that we work in, just like each of the individual members that we work with, right, brings its unique kind of landscape challenges, strengths, and each of our programs is designed differently to address the specific, goals of the state. So I think both Louisiana and Wyoming and Nevada are high fidelity wraparound programs where we're really working to ensure that a high level of care coordination is available to youth and families in the states. But each of them do that through different mechanisms, and we actually, we can build on the strengths in a single area to be more successful in other areas. So for example, in Louisiana, we've built out our wraparound agencies in a very specific way. We have wraparound agencies across the state, and we work with those to coordinate care, to ensure access to both care coordination and resources for the youth and families that we work with. And each of those sites was built out with a certain level of training for each of the staff. In some of the other states we work with that are more rural or frontier areas, we've looked at different ways to bring different staff in and to find ways to create access to those resources in more rural areas and greater expanses of areas over space. So looking at how we can bring people who have different skill sets, but understand their communities and know the resources that are available and understand the people in the communities. And in some spaces, we might work more with people with lived experience rather than people who have a specific degree, because they bring a strength and wealth of knowledge that's unique to that area, and have allowed us to build and not only build out the resources, but create workforce development opportunities and allow people who want to move forward in training or education to have those opportunities to access that.
You touched on the system of care, kind of that approach. Each system might offer something different, have different strengths, maybe needs, opportunities. So it sounds like the team kind of tries to diagnose or at least triage in a given area, how to best implement that system of care approach.
Yeah, and I think I think the approach of each state is unique, and we see different successes, and we incorporate those successes as we go and how we shape our approach moving forward. Yeah, the system of care, we want to make sure that youth have the opportunity to remain in the home and community and receive the services that they need. And we want to make sure we're building strong partnerships with all of the people who are interacting with youth and families. And because we know we'll never be successful in a vacuum providing services for youth. So we want to make sure that we're utilizing all of the resources available in the community. And so we build those partnerships. And but the strengths of each unique state, of each unique region in each state, and the priorities for those youth and families are very different. And so I think how the system builds and works to meet needs, it's really unique to the local area, to the people, and to the community.
Right. That's neat. But again, it gives that flexibility, it sounds like, to figure out what is existing in that area. Our approach is mental health from the Magellan standpoint, right? But the systems themselves, it sounds like there's overlap with other systems within that area. So I'm guessing like school, child welfare, maybe other potential supports and available resources in a given area.
Yeah, and I think our approach is that, if we can create, we know that the children and youth with complex behavioral health needs are going to interface with all the systems that you're talking about. And we know that from the evidence that we have and working with youth and families over a long period, our program's been pretty successful in New Orleans as well in Louisiana over the last decade. And what we've seen is that when care is coordinated, family-driven, based in the community, and we connect across these systems, we see a significant improvement in outcomes. And I think that's one of the things that high-fidelity wraparound is a really interesting approach, right? It's an evidence-based approach to connecting to these systems. It's really family-focused. And I will say, as a child psychiatrist, MDs will get a bad rap for knowing everything. I was really confident about I was really confident in the discharge plans I put together for the kids and families I was working with when I was on the outpatient unit, right? I had an idea about what they needed. I'd worked with them and wanted them to get really specific resources when they were leaving the hospital. One of the things that I had the good fortune when I came to work in the coordinated system of care, I was working with the same youth and families I had seen in the hospital, right? The criteria for our program is that you're with between 5 and 20, and you're at risk or in out-of-home placement, probably because of a behavioral health reason. That's it. And so those were the kids and families that I was working with on the inpatient unit, right? They were the youth who were coming in and seeing hospital stays, maybe seeing residential stays as a result of, not having success with inpatient stays. And I was making all these recommendations, and then as I came to Magellan and really looked at it from this lens to the lens of wraparound, really realizing that a lot of those services were not getting to the families, and that they weren't the services that the families were identifying as a priority. And so being able to step back and, as a provider in the community saying, wait, why is someone who's not a doctor making recommendations that are different from mine? And is that a good thing, right? Being able to say, wait a second, if I step back here and we create an opportunity for the family to have a voice, for their priorities to be heard, then we understand how to get them to resources. So one of the things that High Fidelity Wraparound does is says, hey, we're going to bring this group of people together, the providers, the family, the child, everyone to the table, all the people in the child's community who have an opportunity to impact this youth. And we're going to figure out what the strengths of this system are. We're going to figure out what's not working in this system. And we're not going to point at a person that's not working. We're not going to say, this is a child who's sick. We're not going to say this is a parent who's not doing the things we think they should do. We're going to say, why isn't this working? And how do we create opportunities for this to be successful? So we're building on the strengths that exist, understanding what the barriers are, and kind of building with the family solutions. And I think such a different approach than families often meet behavioral health with. I think of all of the times in my career when a family or youth or an adult voice is not heard, sometimes because we're not listening, sometimes because it can't be the driver of a solution. There's lots of times in behavioral health where people are making decisions for people. And I think to create opportunities, and we really encourage early referral to us. Hey, if someone's not getting what they need, send them to wraparound, not to the emergency room, because let's get them what they need up front, right? Let's not wait until these opportunities, the situations where the first time a family's interfacing with behavioral health is an ER or a hospital, or I can't take care of my child, I don't feel safe. That's not when we should be intervening. But very early, hey, it's hard to get to outpatient services, then you want some help, come talk to us and let's figure it out. And I think one of the biggest things that I've really learned in real life as I've worked with families in this capacity is that, and I will say, as an aside, part of my job description says I cannot dictate a service for a family. And I think hurt my feelings when I first got here, but is such a great testament to the commitment to the wraparound model, right? That the family and the child are driving the plan. And I think when you say to a family, hey, what is the number one issue? Well, it's that my child is being sent home from school every day and I can't work. So you can talk to me all day about getting to an outpatient psychiatry appointment, but I can't get home. I can't get out of the house to do that, right? Because now I'm trying to work another job that doesn't have as good hours as the job I had before because I'm home because my child's coming home from school every day. And so if we don't address that issue, I can recommend all of these very highbrow clinical services all I want, and a family never sees those.
Yeah.
And so when we start to meet the family where they are, what are the three biggest needs that you have? Okay, it's that, is that you need to be able to work. You need to have the resources, to take care of the other kids and family members in the house. And when those things are done, then you have the capacity to meet the youth needs. Okay, let's do these things. And let's start with something that, what if we bring the resource to you? Can we bring the resource to the home? And now we're creating an opportunity where the family can be successful. And that's very different from me in an inpatient unit saying you should see a medication management specialist, right?
Yeah.
Or trauma-focused CBT or any of those things. And a lot of what we find is that many of the youth and families that we work with benefit from those engagements in a way that doesn't require leaning on all these big formal services, but the stabilizing the system, meeting the needs that they're identifying, not the ones that I might identify. And I think when you look at how High Fidelity Wraparound started, it was with what people saw was, hey, there's these families who are being told to do so many things by so many different people. Right now, juvenile justice has a plan for me because my kid got in trouble. And when my kid got in trouble at school, child welfare was one. Now I have child welfare and juvenile justice talking with me about what I need to do this meeting, see this doctor. They've recommended 2 different doctors that do the same thing. They've recommended 14 different kinds of therapy, and I'm overwhelmed, and I can't access any of those because I have these barriers that create issues. And so I think it's been just amazing to see the impact of shifting the system and looking towards. And as an inpatient provider, I believe there's value to the higher level of care services. I believe inpatient is a necessary part of the system. But if we don't have a discharge plan that brings the youth home to the services they need with the capacity to reach the services they need, then inpatient isn't effective, and all of the other higher levels of care become less valuable.
Yeah, it really puts that kind of control, for lack of a better word, or at least their voice is clearly represented in the decision-making process, and it sounds like that allows for a stronger connection, just based on practical things that might need to be addressed that within the system we sometimes assume, or just kind of, we're moving at a very fast pace, so we might not necessarily think about a very basic thing that could be an enormous obstacle for a family to connect on those service recommendations, right? And it also then, I think, empowers the individual, whether it's the child, the family, or both, from that point forward to hopefully make the most out of those services, really maximize the benefit of whatever is available and appropriate. So it sounds like it really, I love strengths-based models. I just think they set people up to maximize their resilience, their own skills and strengths. And the most important thing, again, as a member and family advocate, my role is to understand the perspective of individuals getting care, their challenges within the system, what we can do better to tackle and address some of those things. But it all comes from their voice and their feedback, and giving that, amplifying that so that those of us within the system can build on that to help them, really, because at the end of the day, they're in a situation where they want to be independent, they want to be autonomous and living their lives and have the absolute best quality of life. So for my money, if we could slow down a little bit and really think about that strengths perspective, it sounds like that really does lend itself to better outcomes. And I'm guessing the data probably demonstrates that too.
It does. And I think, and I'll add, and then I'll give you a few numbers from us. I think the other big piece, right, is that we put families in situations where they can make good decisions, right? So it's not just saying, what would you like to do? It's saying, wait, here are the resources, and here's the evidence for this being a really good intervention here, but these are the other alternatives. And so, okay, well, so maybe this evidence-based service is too intensive right now. Maybe this isn't something that's going to work. Let's try this piece that makes sense, but let's keep an eye on how it does, right? And let's be outcomes driven, right? Let's say we're going to look at this in a month. We're going to come back, or if there's a crisis, we're going to come back and we're going to say, hey, this was our measure for success. Did we meet this? Well, we did. This is awesome. So this is a great plan we've got in place, and we're going to build towards something. Or this, hey, maybe this wasn't the right approach, and we're going to step back and we're going to revisit what might be a good alternative. Remember those things that we discussed. Maybe there is a resource that would be beneficial, and we can put some things in place to help you access that more intensive service. And we're going to monitor, and we're going to see, hey, look, no hospitalizations for a month. We're on the right track. And kind of celebrate that. And I think the other piece is exactly what you said. One of the things that's the most exciting to me, right, is that we're building on the strengths. The goal of wraparound is not to put all the services in place and keep all the things in place and engage the family in a lifelong commitment or reliance on formal supports. It's to shift them towards building those strengths. And so when you see over time the community strengths coming up, you see natural supports, right? We hear about like coaches attending child and family team meetings, or members of someone's church, or other family members coming in and being a piece that strengthens that system, and shifts that reliance away of all the formal pieces that we tend to use to identify people as not well. It's really exciting to see the systems become successful. And so I think, in Louisiana, when we look at the system of care, one of my favorite statistics, and it's kind of a funny one, is that 100% of people in our program get high fidelity wraparound. And it seems like a silly thing, but it's such a big thing, right? Because it means we're doing what we intend to do. We're creating that care coordination opportunity for all of the families that we work with. And then, I think if you look at 100% of the youth who come into that system meet criteria for inpatient or higher levels of care, and only about 6% of the youth that we work with see a higher level of care while they're with us, or discharged to a higher level of care. So 94% of those kids remain in the home and community, discharged to the home and community, and are using those resources and allowing them to stay with their family and what we think is a preferable setting. And we see significant improvements in their clinical and school as we go. So it's, to me, that's the most exciting piece, is that we see the outcome that instead of that reliance on hospitals. And I think the other big thing we see is that we'll see hospitalizations in their early part of their stay with us, will be part of their crisis plan, part of the course that they follow. It's a resource that is necessary, right? When kids need a safe space at times, but we'll see those hospitalizations tail off and decrease as we pass that first 3 months in our program. And so it's really exciting to see as you start to build up the resources for the family and the community and the strength of the family, that kids are staying home.
And you could see it through the data visually represented. Like you said, you could see those trend lines going in directions that, everybody involved that has a stake is hopefully pleased with. And again, that I would hope kind of build some confidence across the board, but most importantly for the child and family that, with the right support, they can take full advantage of what's available and appropriate and needed, and kind of, as I said earlier, become very independent in their own care. And I think that's what the vast majority of people really want.
And now, a brief word from Magellan of Pennsylvania. We're here to support our members and their families. If you are a loved one or a Magellan of Pennsylvania member and need information about your services, please visit us online. Find answers and resources at www.magellanofpa.com. That's www.magellanofpa.com. And now, back to the show.
Yeah, and thinking about that, just kind of resilience and strength and moving forward, just interested and curious, have you seen since the pandemic, of course, that was a huge thing in terms of mental health, and we've heard a lot of discussion and a lot of concern related to, in particular, children's mental health post-pandemic. But have you seen providers and even Magellan kind of adjust their approach since the pandemic to, I guess, meet maybe not new needs, but an increased need, or maybe there are some newer needs that have kind of cropped up since the pandemic. So I'm interested to get your perspective on that.
I do think there's some things that are consistent, and then I think there've been some things that have changed since the pandemic. I think a lot of the leadership in kind of the children's mental health space really said, "Hey, this is an emergency." When we saw some of those changes during the pandemic, I think from a provider standpoint and what we see, as a managed care organization, I think we've seen higher acuity presentations. So I think we're seeing kids come in who really are more complex. And I think that creates challenges to the system. We're seeing higher rates of, reports around symptoms of depression, all of those pieces around reports of thoughts of suicide and attempted suicide in some of the age groups that we work with. So I think that higher complexity is real. I think increasingly during the pandemic, one of the things that we saw was emergency rooms start to become an access point. Because a lot of other resources weren't available. People weren't feeling comfortable to go to other resources. And we saw a significant increase in behavioral health presentations to emergency rooms. And I think that's continued. I think workforce shortages have impacted the system in a meaningful way. And that's not just in behavioral health, but it's also when we think about our child welfare systems, right? And in a lot of our states, the number of available placements for youth who needs a placement does not align. And I think that creates a lot of pressure on the child welfare system, but also on the behavioral health system, because we know because of increased rates of trauma that those children may be interfacing with the behavioral health systems. I think schools have increasingly started to play a bigger role in behavioral health. I think there have been more and more efforts to increase access through schools, because we know that's where we can reach youth. And so I think that's a really exciting shift. And then one of the other big changes for me is that telehealth has come in, and we really have to talk about how telehealth can play a role in the system in the future in a different way that I think we talked about a decade ago, and what the role for telehealth is, and where we can optimize telehealth and where telehealth maybe doesn't fit. And so I think the other big changes we've seen have been at a managed care level. I actually think the expectations for managed care organizations have changed a little bit. And I think it's no longer, and I agree with this, but it's no longer just we're paying for things. It really is looking at, are we providing all the resources in the system? Are we looking at early intervention? How are we doing care coordination? Are we engaging with schools? How are we supporting the crisis system? All of those pieces, I think, we're playing a bigger role in taking responsibility and accountability for building out that systems and making sure that systems work. And I think, it's a great responsibility and opportunity.
Yeah. And I think for everyone, but in particular for children, I'm thinking the impact of what I would think would be a very traumatic, not event, but time. I mean, an extended period of time where there was so much uncertainty. The people that they would look to as young people, their parents, their teachers, also weren't sure necessarily what to say or do or how to best support them. So just thinking about the impact of trauma and kind of how the system and perhaps Magellan have had to adjust there as well. You kind of touched on that when you're running through kind of some of the ways that things are a little bit different and some of the things that now do exist, and a heightened awareness certainly. But I think trauma probably has got to be that thread running through a lot of what's happening right now out there.
I think it is. And I think, when you talk about trauma related to the pandemic, it's so unique, to an individual's experience. And I think regionally, this was experienced so differently. The way this was, even the way COVID was managed in New Orleans compared to the rest of the state of Louisiana was very different. And I think the trauma piece and the impact, it's one of the things that I always try to talk about whenever we're talking about children's mental health, is to talk about adverse childhood events, because I think that it's one of the things that we tend not to talk about. Trauma is something that so many of us experience, that it's really a population health issue, right? It's something that impacts so many of us, and we don't want to talk about it. And I think when we think about the increased trauma that many of our youth experience and adults experienced over the pandemic, the loss, the impact on supports and how kids were supported and the resources that were available to support them, it's such a huge impact. And I think even when we think about trauma in general, when we think about, right, like, are you familiar with the Adverse Childhood Experiences study? Have you ever heard of that?
No.
Yeah. So there was a study done at Kaiser Permanente that talked about these adverse childhood events and kind of divided them out into different experiences around, like, in the different categories, but looked at what the impact of having these negative experiences that we think about as trauma, loss of caregiver or abusive situations, or neglect, all of those kinds of things that one might experience over their lifespan. And they looked at those and looked at what the impact of having even a single one of those was on your life over time. And they learned that, almost 2/3 of adults report one of these adverse childhood events. And about 1 in 5 report multiple of them, and about 1 in 6 people report 4 or more. And we learned that exposure to trauma is kind of dose dependent on how it affects you over the course of your lifespan. So the more trauma you endure, right, it can have a bigger impact. We call it like a dose response, right? The more you get, the bigger the response. And every time you add one of these kind of adverse events, you increase your risk for things across, not just behavioral health. We think about behavioral health diagnoses like depression and things like that, but also substance use, early death, chronic disease. And, one of the things we'll see, even in children, we'll see asthma and diabetes that are harder to treat when children have a more significant history of trauma. In adults, some would argue the leading preventable cause of things like heart disease, chronic lung disease, liver disease, obesity, all of these things are impacted in a dose-related way to the trauma that's experienced. And so I think it's a huge impact that we always have to talk about and take into the context of things, particularly because we understand that we can mitigate it, right? That trauma causes people, particularly right when we talk about kids, that kids will adapt to survive traumatic experiences, but the adaptations can come at a price. And so we know that it changes the way you respond to stress, and it can increase your risks for long-term inflammatory processes and diseases that go beyond behavioral health. And so I think the best thing is we know that if we intervene early, that if we can buffer that kind of stress and that kind of trauma and those experiences, that we can change the trajectory on the behavioral health piece, on the physical health piece. And so, building out these systems of care and thinking about increasing access to resources is such a huge opportunity to impact that with the work that we do.
There's all the other parts of the person and their life that are also a big part of that. In other words, to address someone's mental health, you may have a co-occurring substance use disorder. You might have all of this trauma or other physical health issues that they're dealing with, family, the whole myriad of issues. So I'm interested to kind of touch on, if you can, the collaborative care model to kind of talk about, and I don't know a lot about it. And I'm sure our audience would benefit from knowing about it as well, because it sounds like, what I do know of it, sounds like a way to really see the total person, to try to, best impact their overall health and well-being.
Collaborative care is kind of a great thing. And it goes back, I think, you were talking early when we first started talking about stigma. Collaborative care is a really cool integrated intervention. And the goal is to bring the behavioral health piece into the primary care setting. And so I had the good fortune to get to work in it hasn't been brought to the pediatric setting too often, but we were able to work with a pediatrics clinic and provide collaborative care. And it allowed, bringing a licensed mental health professional into the clinic setting, available to pediatricians, so that behavioral health treatment can start in the primary care clinic. Now we don't have to go to a psychiatric resource. Now we don't have to identify a psychiatric resource and get to a psychiatric resource to get help. We can get help in real time in a place that most families and kids are comfortable, right? In a primary care clinic, and then have access to psychiatry where it's indicated to prescribe and provide the resources that are necessary for kids who may be having some simple behavioral health presentations in the primary care clinic. And one of the things that it does is it reduces the pressure on the psychiatry resources in the community, which can sometimes be kind of shorthanded, by allowing treatment to continue with the primary care provider with the support of a consulting psychiatrist. And so we were able to do that and see some really good outcomes, right? In a single clinic, we had 56% of the kids who were enrolled really engaged effectively in the program and stayed with the program and completed the program. And we saw a 40% reduction in kind of standardized measures for anxiety. And so in our program, we were really focused on treating depression and anxiety, and we saw those reductions in standardized numbers. And one of the other things we saw was that less youth from that clinic were seen in emergency rooms, were seen by outside psychiatrists. Their management was able to be successfully completed with the primary care provider in a low stigma setting where there was easy access and resource, and where parents felt more comfortable. Kids felt more comfortable.
Yeah. I mean, it just sounds like a model that lends itself to, where you're going. It's a place of, maybe a little more comfortability. You can get all of your care, or a lot of your care there. And it sounds like the data demonstrates that that's helpful. That's productive. Like, it's showing very positive outcomes, certainly. Just the example of, or the data point where you're seeing less emergency room visits, right. Which probably translates to less crisis, which means that while folks are in the community getting care, it's care at a level that's least restrictive and hopefully most beneficial, going back to what we were talking about earlier, where they're hopefully maximizing what they are receiving. And if there are other ancillary issues that they're dealing with, that's getting handled as well.
Right. And we're integrating, right? So now we have their primary care doctor who's screening regularly for behavioral health symptoms. We're no longer saying behavioral health gets managed somewhere else. Mm-hmm. And we have someone they can go to manage all those other pieces. Hey, this medicine's not making me feel good. Can I talk to you, right? They're not having to go to multiple places. None of those pieces of care are being siloed. And we're able to work together in real time, even in safety situations, to make decisions together for kids and families.
Yeah. Again, I think about the more historical setting where you would have your behavioral health in one office and a physical health doctor somewhere else, and maybe a specialist if you had something else going on, and you would need to get releases signed, just as a very basic logistical piece in order to coordinate that care. Here, it sounds like that simple obstacle is eliminated and folks are talking. And again, I think that sounds like it's very beneficial in terms of what the outcomes are showing.
Yeah, and it was exciting because and increasingly then we have primary care doctors who are becoming more comfortable. They have access to resources. They're asking questions. They're working with us. because I think, it's challenging to be asked to manage things outside of your kind of area of specialty. Pediatrics is a big specialty. And so to be asked then to tackle behavioral health issues because there's challenges in accessing resources, I think, it's experience and building confidence and experience, I think, creates opportunities.
And now, a brief word about 988. Life can get heavy, and sometimes it feels like you're carrying it all on your own. But you don't have to. If you or someone you know is struggling, help is just 3 digits away. Call or text 988 to reach the Suicide and Crisis Lifeline. It's free, confidential, and available 24/7. Whether it's a mental health crisis, emotional distress, or just a moment where you need someone to listen, 988 is there. You are not alone. Call or text 988 today. And now, back to the show.
And looking ahead a little bit toward the future, what are some of the team's strategic goals, thinking kind of near term and also maybe longer term? And then from a kind of what we're going to do to achieve those goals, what's the kind of plan to tackle those and to achieve those goals?
So I think our goals are always, like we're excited that, that we have an expertise in working with youth. And I think when we talk about youth, we're talking about complex youth, all the way through. And I think, we want to continue to build. We're really confident that increasing access and providing the resources to keep kids in the home and community is kind of our goal. And so anytime we have an opportunity to build or look forward to that direction, we want to do that. And I think that's looking at intensive care coordination, high fidelity wraparound. But I also think it's making sure that we understand the entire system of care, and that's not just the home and community-based resources, right? It's making sure that we have a really good understanding of the inpatient level of care, of the residential level of care. And I think residential psychiatric treatment has come under a lot of scrutiny recently because there have been some concerns. And so I think while we focus on that piece where we want kids to spend most of their time or all of their time in the home and community, we also, are really building towards, I think, expertise in understanding those types of resources in higher levels and supporting those resources that are really high quality, that will be successful for youth and families, and how we approach those in a way that can be successful for youth. So I think that's a real area of focus. I think continuing to build and strengthen a full system of care for kids and families where we work. And I think making sure that's accessible to everyone. One of the only things about high fidelity wraparound that I sometimes balk at is there's some things you have to do it right. When we talk about a child and family team, to have a family who's able to commit kind of a lot of time to an intense level of service, right? A family that wants to have people in their home, which is a lot to ask. I don't always want people in my home. And I think, particularly when we think about people's experiences with behavioral health, that may not be comfortable, right? A lot of people have faced settings where someone's taken away their rights or taken away their rights to their children or had those kinds of experiences and may not feel comfortable with having people in their home. And so I think looking at ways that we can continue to provide resources in unique ways and making sure that our programs are not exclusive, even when a model may be. And so I think that's one of the goals I think we have, is to make sure that we're providing access to everyone. And no matter what their family or their needs might look like, that we're building to address those barriers and thinking about that in a system way. The other piece for me that we're always looking towards is how do we create opportunities to resource youth and families sooner? And so, we're just starting to implement our 0 to 5 program in Louisiana, which is the early childhood services and supports, where the goal is to bring a little bit similar to the goals of wraparound, but a different approach. Not a lot of our 0 to 5-year-olds are wanting to lead their child and family team, but we want to make sure that we're providing resources where parents have a voice, and that they have access to resources that are appropriate for that age group. So really trying to make sure we create opportunity resourcing to those youth. And that's a program that focuses on resource navigation and evidence-based practices for 0 to 5. I think when people hear infant mental health, that sounds a little bit weird sometimes, but I think, these are kind of evidence-based programs that engage families and youth together and kind of work on, hey, what does it mean when your child does this, who's not talking yet? That can be, it can be sometimes hard to interpret, especially for new parents. And so creating opportunities for them to engage and build their strengths, and also, work with approaches that'll be most successful for kids. And so that's a program we're really excited about. And, I think for me, where our average, we see kids, I'm often talking about a 14-year-old who for the first time is getting access to mental health resources, when we get to talk about how we approach a 2-year-old who for the first time is accessing resources, and we're connecting the family to services and, maybe supports for food or supports for housing and those types of things. And we're impacting early. It's really exciting to get to see that. And so I think that's another area that we're really focusing on moving forward.
Wow. So a very full plate, obviously, in terms of goals, but one that sounds very worthwhile. So we're kind of shifting toward the end of the conversation here, but we ask each of our guests a couple of final questions. The first one relates to stigma. So one of the missions that we set forth for this podcast, and one of the pillars we really wanted to build it on, was around doing our part, even if it's a small part, to reduce stigma through these conversations. So help people to have conversations related to mental health, substance use, and feel a little more comfortable about those conversations in a helpful way, hopefully. And so I'm always interested to hear from our guests their perspective, and to hear from you maybe over the arc of your career to date, your experiences and perspective on stigma and mental health, and maybe in particular children's mental health, and whether or not you've seen any progress. Are we making any headway? Are we getting anywhere with helping to reduce stigma? You touched on a little bit earlier due to integrated models, right? And just kind of setting that kind of framework, but just generally interested to get your take on stigma and mental health.
It's a significant issue that I think I think I have seen improvements since I started as a psychiatrist, but continue to be something that we talk about every day as we approach working with youth and families. One of my earliest experiences was as a resident in the psychiatry emergency room, and I'd been working overnight, and it had been a busy night, but a typical night. And I got a call saying, hey, an emergency room staff reached out, and you did a really good job in the emergency room last night, and I wanted to, we wanted to make sure we acknowledged that and told you what a great job you did. And I kind of said, well, what do you mean? And they, because it was a typical night, and they went through, and I said, that it makes me a little bit worried, because that sounds like being courteous and being respectful to our patients, and I would worry more about that standing out than about me having done something significant, and I think that's always kind of stuck with me, is that again, often people who interface with the behavioral health system are not met in places where their rights may be respected, sometimes because they can't be, but that they might not feel respected, even at times where there's, that shouldn't be the interface. And so I think it's something that has always stuck with me. I've definitely felt the difference. I can tell you there's stigma in being a psychiatrist. When I ran into families that I worked with as a pediatrician, they loved to see me coming. They ran. As a psychiatrist, I intentionally don't make eye contact. I don't want anyone to know that we have a relationship, and out of respect for the families that I work with. And so it's this very unique, very difficult thing to meet under, I think. And I think we can always do better at it. I think when I work with high fidelity wraparound, when I work in the systems and with the people that I work with, I do see a significant difference. I think that as we break down silos between different sectors, as we work better with our partners across the system, I think we can see that stigma start to break down. And I think the more that we can do to bring behavioral health into common spaces and talk about it in common spaces, whether it's on a podcast, whether it's in the pediatrician's office instead of in a mental health clinic, whether it's some of the clinics that now we're seeing multiple providers in those spaces, right? Where physical health and behavioral health and are all being provided in the same space, like our FQHCs. And I think those are all opportunities where we're seeing the system invest in integrating. And I think lots more to do. Yeah. But we're off where there's opportunity, and so I think great work can be done.
Yeah, it's pretty consistent with what we've heard from other guests, which is we've made progress, certainly, but there's a lot more work to do, and we have to continue to do that work. And so on this podcast, we're going to do our part, even if it's a small part, through these conversations. So, and our final question that we ask each of our guests is our one thing question, and we've covered quite a bit of ground, so sometimes hard to boil it down to one thing. But if there was one thing or the most important thing you'd want the listeners to walk away from this episode now knowing from your perspective, specifically related to Magellan and the work that we've talked about around children's behavioral health, what would that be?
I think I'm really proud of the work that we do at Magellan. And I think we really approach things and design our programs thinking about the unique individuals that we work with. And the unique kind of landscape and circumstance in which they live, and that we're really working hard to make sure they have access to what they need when they need it. And I think that's probably the thing that I'm most proud of, is that that's how we think about what we're doing, and it's the priority, and we believe that people and the people that we work with will be better and have more opportunities for success because we're able to do that. So I think that's kind of the driving force.
That's a great message, and it just says a lot about how much you care about the work that you do, and clearly the people at Magellan care as well. So, well, listen, we really thank you and appreciate your taking the time to sit down with us to have this conversation. We wish you all the best going forward with continued work that you're doing, and just can't thank you enough.
Thanks for having me.
Stick around. We'll be right back to wrap things up. So what did we learn in this episode? Well, we learned that care works best when it's built around the family and child. Magellan's model focuses on keeping kids stable at home by coordinating services and reducing the burden on families to navigate care on their own. What really stood out is that involving families isn't optional, it's central. Youth and families are consistently included in decision-making, so care is shaped with them, not delivered to them. And finally, integration drives speed and access. By embedding behavioral health into primary care, providers can assess and support patients in real time, without referrals or delays. It's a model that's already working for adults and is now proving effective for youth. We'd like to thank our special guest for this episode, Dr. Jamie Hanna. We'd like to thank all of you for listening to this episode of the podcast, and we invite you back for our next episode. If you have any questions or feedback about the podcast, or have suggestions for future episodes, send us an email at mbhofpa@magellanhealth.com. And if you enjoyed this episode, please help us grow by liking and subscribing. We also have some exciting news. The Behavioral Health Matters podcast is now available on all major platforms, so you can listen wherever you find your favorite shows. Thanks for being part of our journey. Well, that's it for now. I'm your host, John Lee, saying goodbye for now. And please remember, behavioral health matters.